Hello everyone, today we are going to start USMLE Practice 1's questions that are related to pathology and we learned in our previous classes. Our first question is that a 28-year-old woman come to the office after finding a lump in her right breast. Her mother died from ovarian cancer at age 34. Her maternal aunt died from breast cancer at age 32. After an appropriate workup, the patient is diagnosed with breast cancer. This patient most likely inherited a mutation in a gene normally responsible for which of following process. First, in this question, we had to guess about the gene that is responsible for the breast cancer, and we have to answer the function of that gene. First, this one is a case of hereditary breast cancer that should be suspected in patients diagnosed at a young age, and a patient with greater than 2 or equal to 2 primary breast and ovarian cancer individual with the multiple family members affected by early onset breast or ovarian cancers. Most cases of hereditary breast and ovarian cancers are associated with mutations in the tumor suppressor genes BRCA, BRCA1, and BRCA2, BRCA2. And these tumor suppressor genes are involved in multiple processes, including DNA repair, cellular differentiation, the checkpoint, control of cell cycle, and for the transcription factor regulation. Actually, first in diagnostic the case is a hereditary breast cancer, and gene responsible for the hereditary breast cancer is a BRCA1 and BRCA2, and these having the functions DNA repair, cellular differentiation, checkpoint of cell cycle, and transcription factor regulation. In these options, the right answer is DNA repair, because in that question we have to tell the function of gene that is responsible for hereditary breast cancer. And if you go to one table, I have in this table from the proto-oncogenes and tumor suppressor genes. Then what is proto-oncogenes and tumor suppressor genes? The proto-oncogenes are normal genes that promote the cell growth. These genes promote the cell growth and division, while tumor suppressor genes are normal genes. They prevent uncontrolled cell growth. Uncontrolled cell growth prevention. Okay? Tumor suppressor genes prevent the uncontrolled cell growth, and proto-oncogene are promoting the cell growth and divisions. And when proto-oncogenes become muted or overactive, they tend transformed into oncogenes. And if inactivation of tumor suppressor genes happens, then can lead to uncontrolled cell growth and cancer. In that way, I want to share one thing. Whenever any disease is coming, if an examiner will give a good scenario to you, and they are mentioning active mutation or activating mutation, then the responsible gene will be proto-oncogenes. If you find a world of activated mutation that is causing a disease or a cancer, then the responsible gene will be proto-oncogenes across MIC, ERBB1, ERBB2, ABL, and BRF. And if we are mentioning inactive mutation, these genes are not working, so their uncontrolled cell growth is happening and causing cancer. Active mutation, there's an overexpression for proto-oncogenes, and they will increase in cellular growth, and they will be contributing to cancer treatment. So if questioning an examiner asking about a mutation, inactive mutation, then genes that are responsible are BRCA, 1 and 2, APC, and beta-catenin, TP53, RB, NVT1, and VHLA. Okay? And guys, it's a very important taper to guys. Kindly note or take a screenshot of that taper. And this is a very important taper, and they are telling which gene is responsible for which function, and secondly, what are most common cancer that is responsible after the mutation of that genes. Okay? Like after BRCA1 and 2, you I get breast in offering cancer. Now we are moving to our next question. Our next question is a 65-year-old man comes to the office for evaluation of 2.5 centimeter nodular skin laying. On the right lower forearm, a mass had been present of 3 months and recently become painful. Vital signs and normal examination demonstrate no rectal lymphadenopathy. No. Biopsy of a mass show atypical keratinocyte within the epidermis that are seen extending into dermis. The atypical keratinocytes have enlarged nuclei with scant amounts of cytoplasm. Keratinization is absent. The neoplastic cells stretched the local neural tissues. PT and CT scan show no evidence of pulmonary hepatic metastasis. These findings are more consistent with vitrophonic. This question they give a scenario for cancer. We have to find its grade and stage. Okay, first we talk about the stage. If we take away tumor T, the marker of degree split, you know the staging mean how much invasive, how much the cancer in region to other part. So it is just a 2.5 centimeter nodal skin laying on that, and it is extending into dermis. Okay, if it extends into dermis, there is a T1 and T2. I get this a low stage neoplasia. You guys know in staging we are using DNM, no lymphadenopathy, so and zero, no metastasis, and zero. But in V into the dermis, T, why not T2? Okay, that's according to that place. But we are done with our raw stage. So no stage, we're having two options. So we eliminate these two. Now it is a high grade or low grade. And you know the grade T, grading mean exemplane and cell differentiation with normal tissues. So if you guys check that it is an atypical. Atypical means does not resemble the normal tissue, and the keratinocyte they're having the enlarged nuclei and scant amount of cytoplasm. So when a cell is a poor differentiating, does not resemble normal tissue, then it's a high grade. If far cancer cell and tumor cell is a well differentiated, is a low grade. If the poor differentiating atypical, then it will be low grade. Our right answer is high grade to low stage neoplasia. Also having one table with pain with the comparison of tumor grading and a staging. The grading means how closely the neoplastic cells resemble the normal cells. And the cell differentiation and staging how far the tumor has spread. The invasion-ness spreadness of a tumor is staging. These are assessed by how we can assess the grading by histopathological science and staging by the technical examination, lymphadenopathy, pathological examination, like growth inspection, and radiological nuclear medicines like PET or CT scans, etc. And what is the criteria? The criteria is several differentiation for the grading. Architecture features and mitotic count, how is epithelium is growing, how it is assembling, that's a differentiation. And staging of a tumor size, non-invasive or invasive, separate two recalif norms and distant registrative. D and F. Okay? And this is a basic differentiation between grading and staging. Now we are moving to our next question. Our next question is a 61-year-old man come to the emergency department due to fever, chills, a protective cough with a thick, bleeding sputum for the past several days. His temperature is 38.8 Celsius from 0 to Fahrenheit. Blood pressure is 90/60. and pulses 110 per minute. On examination, the patient is lethargic and ill-appearing, and the bronchial resounds necroechoes are present in the right lung. The blood and sputum cultures called Klebsiella pneumoniae. It's determined that the bacteria express a lipopolysaccharide on their outer membrane surface. This stimulates door-like receptor in the inflammatory host. This in turn usual degradation of IKB inhibitors protein. Okay? Which normally binds to a latent transcript factor found in the cytoplasm, which are the following factors more likely tricky activated by the removal of this inhibitor protein. IKB. The IKB is attached with one factor, that is NF. KB, and it stands for nuclear factor kappa B. Nuclear factor kappa B. Understand? First, moving forward, I want to make it a bit description because answer is already clear. It's a nuclear factor kappa B because it gives a hint of IQB inhibitor bonding. So let me tell you the mechanism. Mechanism is that these are one inactive compound, it is nuclear factor kappa B, and it's a part of transcription factors that perform a critical role in immune response to infection and inflammation. In inflammatory cells, nuclear factor kappa B is a non-represented latent inactive state that encounters inhibitor protein with IQB. Okay, when any factor, any stimulus, it gets the growth factor mitogens, inflammatory cytokines, bacterial product, they activate one enzyme that is IKB kinase. The IKB kinase separate both compounds like IKB inhibitor and NFA-KB by the ubiquitations. Then this results in ubiquitation and subcutaneous destruction of IQB with a release of free nuclear factor kappa B. Okay, and this IQB is degraded by the prokaryotic degradation, and after the nuclear factor kappa B, it's free. After it's free, it once free, the nucleus promotes us enters in the nucleus. What it was in a cytoplasm. After activating, it will go to a nucleus and promote the synthesis of a number of inflammatory proteins such as cytokines, acute phase reactants, cell adhesions, molecules, and leukocyte-related growth factors and inflammatory cascades circulating as nuclear factor kappa B also stimulate the transcription of more IQB ultimately binding the free NF-KB. And after that all the things, again I am going to summarize that the nuclear factor kappa B is inactive because it's either attached with IQB inhibitors when it's get stimulation like growth factor mitogens, inflammatory cytokines, and bacterial protect. They activate one enzyme IQB kinase that separate both two compounds, and nuclear factor kappa B will be free and it will go into the nucleus and will create the nucleus and give a response for the immunity, inflammation, and cell proliferation. And it is responsible for the inflammatory response and all the thing they need. All Christian, there is one bacteria that equate to bacteria product to the inflammation causing the disease, and you also let know the polysaccharide on the outer membrane surface that stimulates the toll-like receptor in the inflammatory cells. These are receptors on which bacteria-productive polysaccharide come and stimulate and in activating the IQB kinase and detaching the IQB inhibitor already. They give all the scenario. The thing, if you know the IQB is attached to nucleic factor kappa B, then you easily click the right answer. Okay? Now we are on to our next question. Our next question is, a 21-year-old woman is hospitalized for elective subtotal colectomy with aortic anastomosis. Due to abnormal colonoscopy findings, she underwent screening colonoscopy because of family history of colon cancer. Her maternal grandfather died of metastatic colon cancer, and mother was also recently diagnosed with colon cancer. The patient had no other medical problems, takes no medication, and does not use tobacco, alcohol, and illicit drugs. The surgeries are performed with no operative complications. The new lesions are present throughout the resected colon, some of which are shown in the histopathology exhibits below. Okay, this is histological slide, and genetic testing is the most likely to reveal a germline mutation, resulting in which of the following effects. Okay? First, we have to talk about this picture. That picture belongs to family here. Adenomatous polypopsis. Okay? If you guys take it clear to the multiple chronic tubular adenomas. These adenomas further having complex ends in this plastic epithelium. And if we segregate this slide, then this is a mucosa. This one is a mucosa. And this is muscularis propria. These epitheliums are elongated. This plastic epithelium is elongated and dark and crowned with nuclei. And these are giving a clear diagnosis of familial adenomatous polyps. In this question, we have to answer which is a following effect that genetic second more likely to reveal about the germline mutation. What is happening in this disease? We have to then. Actually, this is the young person, and we diagnose the disorder of the familial adenomatous polyps. And secondly, if we talk about the germline mutation, the mutation happening by the tumor suppressor gene, adenomatous polypsis coli. In fact, the most commonly that disease happening due to one of gene, if you guys know, it is APC. Okay? And full form is adenomatous polypopsis coli. And in that gene, there's a loss of function. And also function of this gene cause the familial adenomatous polypopsis. Okay? So the right answer is lots of function of APC protein. Actually, these are my line is some important points though. If you guys know, you can give it answer within seconds. This question no hence main concept, but the main thing by the history you have to get the diagnosis, then diagnosis with the familiar adenomatous polypsis. Then you have to get the question, but they're asking about the genetic findings. But your gene is affected, then this disease is happening. It's already mentioned in Jake chapter, if you guys also in general pathology is mentioned Neoplasia, but so it's loss of function of APC protein is still happening, okay? And it is also example of inactive mutation. And inactive mutations have been in tumor suppressor genes, okay? And is there one thing more? The APC plays a crucial role in generation of both hereditary and the spontaneous forms of colon cancers. Nearly 80% of spontaneous colon cancers is spontaneous mutation to the both sets of APC genes that reminder typical has activating mutation to the downstream products of APC pathway. But basically, the most of 80% of cases of colon cancer is happening due to the loss of functional APC protein and inactive mutation. Okay? Now we are moving to the next question. The next question is social scientist injects hepatocellular carcinoma cells into the liver parenchyma of an experimenter. Big Repeated observation showed that the tumors have progressive proliferate and invade the liver parenchyma to form a large mass. After some time, malignant cells began to penetrate the vascular basement membrane to gain access to recirculation. During the process of basement membrane invasion, expression of which of the following substance most likely to be increased in tumor cells. Now, in this scenario, they are saying they inject one tumor cell, that tumor cell grew, increasing size, and it formed to penetrate its basement membrane and move to bed vessels. If you guys remember about the neoplasia progression, in that topic, we have the normal cell after a stimulative dysplasia, after dysplasia carcinoma in situ, and after carcinoma, there were invasive carcinoma. In invasive carcinoma, the cancer cell invade the basement membrane due to some enzymes like collagenase and hydrolase, and these enzymes are called metalloproteinase. Okay? The metalloproteinase are enzyme that are responsible for the breakdown of basement membrane, and if you guys know, the basement membrane are composed primarily of laminin and collagen 4 7. And these enzyme participate in many physiological processes, tissue modeling and evagenetism, but for the basement membrane penetration for the carcinoma, they are 100% responsible. And also an important point is, if they are saying about differentiation, that the cell contact, there are two things, like the cells are growing, they are attached with each other. But if they are saying there's a breakdown between the cell and cell contact, which thing is responsible? Then adhesion expression of adhesion of molecules are responsible thing with adherence. Okay? But the right answer for this purpose, how the basement membrane going in figure, how the basement membrane going to destruction, that is due to the metalloproteinase. That include collagenase enzyme and other etc. Okay? Now we move to the next question. Our next question is, a 50-year-old man is scheduled to undergo a colonoscopy for a routine colorectal cancer screening. He has no abdominal pain, gross blood in stool, constipation, change in stool caliber, unintentional weight loss. He also had no family history of colon cancer. The procedure is uncomplicated, but the patient is found to have a small microcell in less than 1 centimeter in his sigmoid corner. The lesion is biopsied and histology is shown in the image below. This is histological lesion. Or as you guys know it, that is plastic lesion from colon cancer. The pathogenesis of this pitching lesion most likely begin with a mutation involving which following gene. We have to tell about the following gene that is responsible for that colon cancer. Okay? If the question basically for colon cancer, and these are all of genes and options like APC, KRAS, P53, because these DCC, they all are responsible for the dysplasia and the mutation and for the abnormality in the colon. But how we can diagnose? First, we have to check the lesion. The size of the lesion is approximately 1 centimeter, okay? And think about the diagram. Okay, so that is a tubular adenoma. Okay? We're having these two factors. Size 1 centimeter and also tubular adenoma. Fine? So, the most responsible gene and the most schizosporadic colorectal carcinoma arise with a classic adenomatocarcinoma sequence, and it is due to APC tumor suppressor gene. Already, the last interview, thus last interview, we can then that the APC is responsible for the 80% of cases of colorectal cancers. The first mutation in this pathway usually involves the APC tumor suppressor gene that is responsible for regulating the cell growth at a young. And secondly, the mutation of KRC and DCC like deleted in colon cancers and P53 are later. Okay, they are asking about most likely begin with the mutation. The colorectal cancer mostly started with APC mutation. Okay, and later to the adenoma to carcinoma, the other genes are responsible like KRCI, Alzheimer's diagrams, like these are known as clonic accuser. Guys, check previous line with a multiple clone epithelium and this plastic epithelium of tubular adenoma. Okay, if you can have a close look, you can check. And if we talk about the question, the adenoma to carcinoma, in this patient, there is an adenoma of 1 centimeter and a question of picking. This journey of adenoma to carcinoma or colocanthus began and started with the mutation of APC inactivation. Tumor suppressor gene, okay? After that, due to COX-2 overexpression, the class activation, DCC inactivation, P53 inactivation, the adenoma converted into carcinoma. But for the thing, if lane is a very small, and secondly, the starting fees or it is a tubular adenoma, the most commonly the responsible gene is APC inactivation. But if it having the more than 4 centimeter in the criterions and cancer is converting into malignant cancer like adenoma into carcinoma, then most commonly the responsible genes are KRAS activation, DCC inactivation, and P53 IMED inactivation. Okay? Our next question is a 34-year-old woman that counted off with due to affect abdominal pain over the past several months. She has no significant past medical history. The patient does not use a tobacco alcohol. Temperature is 36.7 degrees Celsius on physical examination. Right upper quadrant for lens is present. Abdominal imaging reveals a dense liver mass, angiography one film, demarcated, highly vascularized tumor surrounded by normal liver. Which of the following substance more likely contributed the most of the blood vessel development in this patient tumor? The thing is that they are saying they are having the tumor. They have patient is having the vascularized liver tumor. But in the last, they are asking question for the blood vessels. If the tumor is vascularized, then from which factor from where that vessel 12? We have to keep this thing. And you know the formation of blood vessels is called angiogenesis, and it's a predominant driver of two substances, guys. Right? Two substances, the angiogenesis. The first responsible is a vascular endothelial growth factor. Vascular endothelial growth factor, and it stimulates the angiogenesis of reactive tissues, and is if the tissue normal or chronically inflamed, healing a neoplastic. It's the first, the vascular endothelial growth factor, and second is FGF, the stand for fibroblast growth factor. It is also responsible for the angiogenesis, and it produces a wide range of cells involving endothelial cell proliferation, migration, and differentiation, and is play important in embryogenesis, guys. And this one is also embryonic development, metapoiesis, and wound repair by recreating the macrophages, fibroblast endothelial cell to damage tissues. So whenever anybody asking to you which factors and which substance are responsible for angiogenesis, then there are two substances, the vascular endothelial growth factor and the fibroblast growth factors. So our answer is fibroblast growth factor. Okay? Don't forget two responsible substances, vascular endothelial growth factor and fibroblast growth factor. Now we are moving to our next question. Guys, already the diagram is just looking like bone. Okay, so first we have to the question: the 18-year-old man is evaluated to 3 months of low extremity pain. The pain is a persistent and present both day and night. Has no fever, chills, history of leg trauma. Imaging shows an expansile lesion of dystrophy. Surgical dissection is performed if the specimen is shown below. And mutation volume which would following genes is most likely present in this patient. Actually, it is related to the bone mesenchyma. And we already done with teamwork about the photo and progenitor tumor suppressor genes. And guys, that is so important about in here they doing you work, we are doing the Neoplasia topic about 20 MCQs just related to that topic. Which gene is responsible for that cancer? We have to learn that table about that proton cogenic tumor suppressor genes. For that, it's the mesenchyma, okay? Then it's the case of osteosarcoma. Osteo mean bone, and sarcoma mean it is a mesenchymal malignant tumor. Okay? The osteosarcoma typically form when the mesenchymal stem cell dwell mutation form in the finally the RB1 and secondly TP53. The RB1 tumor suppressor gene which encodes for the RB protein that regulates cell cycle progression. Inactivity in mutation of RB1 promotes unchecked and upregulatory cellular replication and associated with the osteosarcoma, retinoblastoma, melanoma, and soft tissue sarcomas. The RB1, actually first you have to remember these two genes are responsible for osteosarcoma, but RB1 is personally responsible for retinoblastoma. Stromal polygen 1, melanoma, and osteosarcoma. And second one is TP53. The TP53 is responsible for osteosarcoma, but with that, it's associated with a leaf-forming syndrome. Leaf-forming syndrome and intense syndrome, there is high risk of multiple tumors like osteosarcoma, soft tissue sarcomas, breast cancer, brain tumor, adrenal carcinoma. So guys, now we have moved to our next question. Our next question is, a 50-year-old woman come to the office for annual examination. She's healthy, taking no medication, other than vitamin D and calcium supplements. The patient did not smoke, drink alcohol, use Allicin. Her blood pressure is 180/69. Physical examination unremarkable. Recent mammogram was normal. Colonoscopy showed 2 polyps which were excites on astrological examination when polyp is small and has early adenoma features. The other is larger and had late adenoma features. Okay? A mutation in vitro phonogen would be most got this patient. Small early adenoma to grow develop late adenoma features. Lady we talk about for the early staging from the early days. We find there is a cancer. Most commonly, the mutation began with the APC inactivation in colon cancer. Further, for the adenoma progression, adenoma 2, early adenoma 2, late adenoma, or adenoma to carcinoma, it's due to some genes that are KRAS activation. There's a P53 inactivation. There was a DCC inactivation. These genes are responsible for this early adenoma-related adenoma, or also for the adenoma to the cancer. The most perfect answer is a KRAS activation, and that is here, the KRAS activation. Okay? Because that progression from the normal mucus to small adenoma, the initial appeared as a small adenoma attributed to the mutation of APC tumor. Small, okay, from normal to small is due to APC mutation. Fine? And then, if with the increase in size of adenoma, the mutation of KRAS To oncogene, it's a to facilitate this step going transform a little lead adenoma by leading the uncontrolled cell proliferation. Because you guys know the chaos, it's a oncogene. They support the overexpressions for the cell division and growth. Normally, the grasin cofila G protein like proteins and it regulates and cycle by stimulating and inhibiting as it is necessary and imitation of a chaos into oncogene from leads to a consecutively activity GTP1 protein. And for the malignant transformation, the protein, that step requires imitation TP53. Again, I want to elaborate it process if there is a normal tissues in want to become a small adenoma. Then the APC mutation is required and found small adenoma to lead adenoma or large adenoma because need overgrowth, extra growth. So it will need a proton gene and that is KRAS overexpression. And for that, adenoma to carcinoma malignancy, we have to need TP53 inactivation. Okay? Don't forget these three genes with their phenomenon acquiring cancer. Acquiring cancer is so important. And again, I am saying if a normal tissue is converting into small adenoma, then APC inactivation is there. For small adenoma is converting to late adenoma, then KRAS overexpression is there. If adenoma, late adenoma is converting to carcinoma, then it requires TP53 inactivation. Okay? Now we are moving to the next question. Our next question is a 44-year-old woman comes to the office with a brief math, the physical examination. With hard fixed math in the right, whereas with the paper, it's like axillary lesions. The patient undergo dissection of a mass at axillary lymph nodes. To the axillary lymph nodes, an histopathologic examination showed ductal adenocarcinoma with local spread to the axillary nodes. And the ability of tumor to reach a drained lymph nodes is facilitated by which are forming into the primary tumor sites. Now, the main question you have to know, think about the breast cancer. It's the main thing they are asking, the ability of tumor reach to the lymph node, this basement membrane, it's a cancer cells, and these are lymph nodes. So, which are ability, which thing they have done, which thing the cancer cells are doing, so they close the basement membrane and enter into lymph vessels. Fine. So that thing you have to told already we did discuss there for the basement membrane, for the basement membrane, the cancer cells are regulating metalloproteinase enzymes, and that include a PLAB. Collagenase in basement membrane is made of collagen 4 and 7, you already know. Then there will be increased production of type 4 collagenase. Okay, first they have to load the intercellular junction, already you guys know, do the downregulation cadherin, E-cadherin, they decrease the cell-cell adherence, and they freeze into a cell, believe the site of origin, then they detach the basement membrane by the increased production of metalloproteinase enzyme that include collagenase hydrolase, and the decondition of extracellular matrices, migration and dissemination. Already this diagram is in front of you that a metastatic cascade. We have to say about this phenomena, how the invasion happen, how the basement membrane invasion migration is happening. It's due to losing of intracellular. First, there's a losing of intracellular junction due to E-cadherin. Then there will be metalloproteinase or collagenase enzymes and releasing the due to detachment from the basement membrane and decondition of extracellular matrices, and then there will be migration and dissemination in the lymph vessels. Fine. Now we are moving to the next question. Now the next question, it's a 45-year-old woman come to the office to do 2-week of persistent back pain. She has excessive fatigue and neuropathy unintentional withdrawals. What the thing they want to us, we have to read lights lie. A genetic study reveals finger nucleotide substitution causing activating mutations, which was the following didn't was likely in more with this patient. Already we told in our first question that activating mutations in the proto-oncogenes, in which proto-oncogene is responsible for its cancer. Its cancer is about the back pain, and first we have to judge about it is mutation of proto-oncogenes or anti-oncogenes active suppressors. It's either proto-oncogenes because they are saying activating mutation. Secondly, they are saying they are having these symptoms and that is more commonly related with colon cancer. And secondly, these are things, the activating mutation, we have to check which of following in them is proto-oncogenes. In these all genes, honeyvine is proto-encoding that of gas, and you guys know in the colon case and the KRAS activation already we are studied in last MCQs. KRAS reduce was small adenoma that convert into large or late adenoma. Fine, it's a so question. It's easy. If anyone is asking about the activating mutation, about activating mutation, then it will be proto-oncogene. If they are asking inactivating mutation, then it will be tumor suppressor genes. Understand? This is one question. These type of question mostly come in your exam asking you for there's a one single statement. In this statement, they are asking two questions, okay? But this thing you have to carefully read this statement because whenever you are done with one question, you can't come back. It is just like that and you have don't waste your time because in this one statement, two questions will be there. Like that, they will write the following question apply to next show items and they're the item number 1 and item number 2. And so we have to read this treatment. A 36-year-old woman comes to office. She noticed some lumps on her arm while getting dressed. She says she feels fine and has no other symptoms. Her medical history is significant for hypothyroidism. Family is negative on X and physical examination and body mass index 24. With examination did not tend in left exhale lymphadenopathy. The patient is sent for ultrasound guided biopsy. Microscopy of the tissue specimens or clumps of the cell. They've had a positive immunochemical staining of cytokeratin. Guys, cytokeratin automatically is a big hint, an important hint. If you guys know it, cytokeratin is a marker. Is it a marker for the epithelium-derived tumors? It's an important point kind to write on your books as cytokeratin. It's a marker for epithelium-derived tumors. And it's also retaining the Neoplasia part of gender pathology in the first read, and you epithelium-derived MCQs. These cells most likely belong to which of following lineages. So you got already known the cytokeratin belong to epithelium. The answer is epithelium. The next version is the cells identified by the special immunohistochemical staining. Okay? And shown to overexpress a 185 kD glycoprotein. The spans cell membrane and tyrosine kinase activity in cellular domain, which will follow most likely function of this protein. First, these are oncogene, okay? You have to recognize the oncogene and basically the oncogene is HER2, that cause for human epidermal growth vector receptor, with tyrosine kinase activity into the intracellular domain as they said in the statement, the intracellular domain in the cell membrane having the tyrosine kinase. These caused HER2 oncogenes, okay? It is known to play to an activation of a transduction pathway that control the epithelial growth and differentiation. Epithelial cells carcinoma that overexpress HER2 demonstrate increase in the proliferation. It increase the proliferation resistance to apoptosis. So if it is giving resistance to apoptosis, then there will be proliferation of cells. The right answer is accelerate accelerator cell proliferation. Answer is accelerates the cell proliferation. Her next question is on the screen. The statement is additional churn subjected. Researchers is subjected. So researchers studying the cell cycle observes a sudden increase in activity of several enzymes, including the dihydrofolate reductase and DNA polymerase, which of the following process most immediately precedes the observed increase in enzyme activity. We are saying researchers doing a study in the cell cycle, and there is a sudden increase in several enzymes, including dihydrofolate reductase and DNA polymerase. So first we have to check in the cell cycle. If you guys on the cell cycle, there are some phases like anaphase, cell division, mitosis. G0 phase is a non-division is going on G1 phase. Pre-sign take-on provision for the cell division for the cell, and S phase is DNA application, and G2 phase is the pre-mitotic growth and DNA damage repair phase. Okay. First, we have to find in which of the phase cell is. According to studies, there's an increased activity of enzyme that is responsible for DNA synthesis, like dihydrofolate reductase and DNA polymerase, that signifying that the cell is in the S phase of cell cycle. According to these enzymes, it is giving a picture the cell is most probably in S phase. So, immediately prior to the S phase is the G1 S checkpoint. This is one checkpoint in which the cells or enzyme, the genes are checking that gene after gene phases any abnormalities present in the cell or not, it is acceptable cell for the S phase or not. For the checkpoint for cell DNA integrity, cell with the damaged DNA not allowed to enter the S phase to limit the propagation of mutation. So this is the one regulator, this is the one gene of a J1 S checkpoint, that is a 15 on blastoma protein, RB proteins. And these proteins are responsible for the regulation of a cell in the G1 S phase. Okay? And our question is asked, which is the following process most immediately precedes the increase in enzyme activity? And that enzyme is the phenoblastoma protein phosphorylation. Okay? What is happening when the cell is stimulated by the growth factor? Division cyclin D, cyclin E, and the corresponding cyclin kinase occur, and the retinoblastoma protein is phosphorylated. And phosphorylated are released the E2 factor which allow progression to radiant phase. Actually, when the phosphorylation is happening, it is during inactivation of RP. When there is inactivation, it is not checking any and not doing any circulation at these points, and easily the cells are going, to G1 to S phase. And due to these retinoblastoma protein phosphorylation inactivation, the cell is going without any checking to S phase. So our right answer is IV protein phosphorylation. Our next question is a 27-year-old woman that comes to office with a healthy A 27-year-old woman comes to the office with a healthy maintenance examination. The patient had no chronic medical condition and no family history of cancers. She has had normal physical examination, including pelvic examination is normal. A PAP test is a performance show a squamous intraepithelial that is positive for the human papillomavirus. A cervical biopsy is performed and reveals low-grade dysplasia, which is a following feature but distinguish the patient login from cervical malignancy. If you guys know about the neoplasia. Progression topic, that was the first topic of neoplasia and gender pathology, therefore, a statement about the dysplasia and carcinoma in situ. The dysplasia is a reversible process if we remove the stimulus, and carcinoma is to an irreversible, a severe form of dysplasia. So in this question, they are asking the same thing. Now, we are taking a pap smear and we are getting a small lesion that's positive from the human papilloma virus. So they are saying it's a low-grade dysplasia, and low-grade is irreversible. And they're saying if I compare the low-grade dysplasia with a cell biomalic, so if I tell carcinoma a malignant tumor, then what will be different between what abundant mitosis, yeah, in malignancy, there will be abundant mitosis. Disorders, maturation, yes, it having. Also cell plurality, it is having. Nuclear abnormality, they have pleomorphism, both having dysplasia, the recommend get, but reversibility changes. If only happening is dysplasia, the right answer is if reversibility of changes. Because dysplasia is reversible, and carcinoma in situ or carcinoma invasive is reversible, so dysplasia persists.